And we're back. We have Joey Scambia. Joey, thank you for coming on, sir. We are going to chat about this very unique experience that you have working at what I would consider kind of an elite academy, the IMG Academy, and the reality of being in that setting, working with kind of freak youth athletes. Joey, would you mind just giving a brief intro and background on yourself?
Yeah. First of all, thanks, Chris, for having me on. I know you guys have had a lot of great guests on, so honored to be one of those people selected to kind of share my experience and just share what I do on kind of a day-to-day basis. So a little bit about me. Name's Joey Scambia. I'm a sports physical therapist working down at IMG Academy, which is down in Bradenton, Florida. I went to PT school at the University of Rhode Island, and then shortly after completed a sports physical therapy residency at Johns Hopkins Hospital right outside of Baltimore, Maryland, and White Marsh, Maryland. And now I'm currently down working as a Johns Hopkins All Children's Hospital employee, and we are the treatment provider of all of the student athletes at IMG Academy.
Can you briefly describe for people that aren't familiar, what is the IMG Academy?
So, IMG Academy is a preparatory boarding school, and it's specifically geared towards athletes. And most of these athletes range anywhere from around 12 years old up to like 19, 20 years old, depending on, if they reclassed or not. So, typically seventh grade all the way up into the post grad year. So, they do even offer that post grad year if, say, someone's injured their junior or senior year, they lose out on film tape, they aren't able to attend showcases or workouts. It gives them that extra year to gain, more skills, more strength, more game experience, more, just overall growth as an individual to get them to that next step, which is hopefully, a dream college that they want to attend. So the academy basically runs youth camps as well all throughout the year for both adults and youth. They have multiple sports. I'll kind of run down the list here. They got tennis, golf are the two main individual sports. And then they have football, baseball, basketball, soccer, lacrosse, volleyball, and track and field. And then depending on the amount of kids that they have for each particular sport, there's going to be a certain number of teams. So for example, there's 3 football teams, 1 national team, which for the national team for each sport, that's going to be like your main top tier team. And that's going to be mostly, your high level recruits, kids already coming in with, loads of Division 1 offers. Most of those kids are going to be on full scholarships. So IMG does do scholarships. Some are on full, some I know that are on partials, and others pay full tuition. And then there's the lower tier teams, which are still very talented. They're just not quite up to par with the national team. So football has 3 teams, baseball has around 12 teams, basketball has 15 teams broken up between boys and girls. Lacrosse has, I believe, 2 to 3. Volleyball just started this year. They have, I believe, 2. And then there's track and field, which is just, whoever is participating in that particular sport. They don't really break it up into, different levels or teams. So definitely a lot of student athletes. There's about 1,200 total. So it's almost double the amount of most Power 5 conference schools. So you are having a ton of kids, just a ton of volume. So that obviously indicates the need for more healthcare providers to help kind of run the show and keep the ship afloat here.
What's the percentage of kids that go to the IMG Academy and then go on to collegiate sport at any level?
So I believe last year, if I'm correct, they had a post at the end of the year. I think about 25% of students went on last year to compete in college, or at least were offered in college. I don't know if that's specifically just the senior class or if it was anybody who happened to be offered, but there is a large amount, whether it's, JUCO, D1, 2, or 3, that do end up at the next level. So it's really like, that one stop shop of where you get all the resources needed. And we'll get into a little bit more on really propelling yourself from, an athlete with not much nutrition experience or leadership experience or mental psychology experience. So you gain all these things that you wouldn't normally think you'd get at a high school, And you can kind of get all of these at IMG to really grow yourself, not only your sport, but just kind of as a person in general.
How you mentioned scholarships and partial scholarships. How do kids and athletes even get accepted or go through the process of going to the IMG Academy?
Yeah. So if you're a prospective student and potentially want to go to the school, you can just go on their website and apply online. You can also attend one of those camps like I had talked about earlier. And if you happen to do, really well, or you perform well, or you kind of gel with the coaching staff, they might be one to, talk with you or the parents after the camp, like, hey, we liked what we saw. What do you think about, if we talk about further steps on maybe considering this for the fall or the spring semester? And then you could also be recruited based on your talent. So not everybody starts here either as a seventh grader or as a freshman in high school. Some can come their junior year, some can come their senior year, some can come only for a post grad year. So it really kind of depends on what that individual's situation is and what their overall goals are, because obviously for a lot of families where it's not a full ride, it's very expensive. So they're kind of viewing it as an investment. Like, if I can get my kid here for a year and they really flourish here and gain all the resources they need, it can help us on the back end. One, they get into the school they want to, and two, from a financial standpoint, they may be getting a lot of money to go to this college, to where it kind of offsets the investment that we made to come to IMG. So it's really like a nuanced situation depending on each particular person. But yeah, those are kind of the three ways that ultimately kids wind up at the school.
Once they get there, what does an actual day or week look like for a kid? Does it look very similar to a collegiate NCAA athlete sport setting? What does it look like for a typical athlete there?
Yeah, so depending on when you go to school, you're either divided into a morning school athlete or an afternoon school athlete, and that kind of correlates with like the sport and the availability of like weight room slots, practice slots, field time, all of that. So if you're a morning athlete, you'll typically be in school anywhere from like 7:30 to like just before noon, and if you're in afternoon school, you'll be anywhere from 1:30 to say just before 5 o'clock. So if you have morning school, then all of your sport related delegations are reserved for the afternoon, and then vice versa if you happen to go to school in the afternoon.
What is the total resources that these athletes have and the staffing involved from a performance staff perspective, medical, wherever you want to go? What resources do they have available?
Yeah, so kind of building a little bit more off like what their afternoon or morning would look like if it was the sports part of the day. So typically it'll be practice depending on where they are in the year, games/scrimmages, team lifts and or speed work. They'll have leadership cut out, mental conditioning cut out, and or nutrition. So these obviously are taught by those healthcare providers or sports med staff members. So as far as kind of the whole multidisciplinary team that's here, we have sports physicians. There's about three of them. There's four full-time PTs. I think we're up to like 22 or 23 athletic trainers, which is just insane to think about. Over 20 strength coaches. There are a few sports scientists, leadership coaches, mental conditioning coaches, nutrition coaches, and the sports coaches themselves. So kind of all of these providers are involved, whether it's an acute injury, a long-term injury, just throughout the school year, because they're going to have those carved out times for their mental conditioning where they're going to work on, difficult game situations and kind of how to overcome those hurdles, leadership sessions on how to be a better teammate, be more coachable, fit in with their teammates, things like that. And then, their nutrition sessions, what should my plate look like? What should it look like in the off season? Once the season hits or once we're ramping up for games or scrimmages, how does my plate macronutrient change? So kind of all those team members are involved throughout their whole experience at IMG. Some might be more involved in certain times of the year or certain scenarios where they are injured. And then some are less involved kind of as the season goes along. So we're all involved in some way, shape, or form. Just our role will kind of vary based on the individual athlete or kind of where that sport is within their season.
For someone that hasn't just looked at pictures of the IMG Academy, I would recommend just going onto the website or looking up the IMG Academy. It's unreal, the amount of resources and facilities, and it legit looks like a sick strength conditioning facility for like a collegiate setting, and all the things they have. So y'all are in a very unique and special environment. What does a typical day look like for you as a physical therapist?
Yeah, so we have the luxury of pretty much being an outpatient physical therapy clinic that just so happens to be placed on a campus like IMG, right in the middle of the athletic training room. So we really function as our own outpatient clinic with the luxury of being able to communicate with all of these professionals within the team. So I treat my standard 8 hours per day. I have some built-in documentation time in that as well. 30-minute treatment slots, 60-minute evaluations. And sometimes the 30-minute slots can be really helpful because a lot of these kids are very, very in tune with their bodies, have good movement literacy, have good understanding of what, certain exercise names are, to where the 30-minute slots allows us to function optimally, to the point where it doesn't get, too backlogged or too crowded or to a point where I'm running around like crazy, because they do have that education that they're getting throughout the year in terms of like their terminology, how they should be performing certain things. So they're very regimented in kind of what their day is like. So it helps us out a lot in the PT area, where some days it can get crowded, to where it's less of, us running around and making sure everybody's doing what they're supposed to. Everyone usually kind of falls in line because they know what to do, based on kind of how their day has gone and their experience here and what they've been taught. So that's kind of my day to day in terms of like, the time I'm in the clinic and patients that I'm treating. It'll roughly be anywhere from like 7 to 12 a day, depending on the schedule. And then if need be, say I have an evaluation, I'm going to communicate those findings right away with the athletic trainer. They're going to kind of be the centerpiece of the whole plan of care, because we're kind of in our own area in the clinic. We don't have the luxury of always being able to contact everybody or talk with everybody, whether it's, their sport coach, strength and conditioning, mental leadership, you name it. The athletic trainer is kind of that centerpiece where they can relay the information to everybody. So I will do an eval, head right to the athletic trainer's office. Hey, here's what I saw. Here are my findings. Here's kind of what I'm thinking this athlete's timeline might be, or what I'm thinking in terms of like restrictions, either in practice, games, or like weight room scenarios. And then they can relay that info to the strength coach. Because with four of us, 22 athletic trainers, 20 strength coaches, and 1,200 students, it's just very hard for us all to find a time for us to meet where there's no conflicts, because the athletic trainers are assigned to each particular sport. Same with the strength coaches. So there are baseball specific ATs, football specific ATs, and similar for strength. So it does create a bit of a challenge trying to find time to get us all in one spot. We do make it work as best as we can. And there's usually, I would say, very few scenarios where things tend to slip through the cracks. I think we do a really good job of bouncing things off of each other and communicating really well to ensure that doesn't happen. And then if I don't have an eval, or if I have, a patient and they're making pretty good progress, or they're kind of nearing the next step in their care, or where I can kind of give them the green light to do more things, then I'm checking in with the athletic trainer again. Hey, here's what I saw today. They looked really good, or we still got to be a little bit cautious with this progression. And they can kind of give me what they've been seeing if they are still participating, because they're the ones out at practice, we're not. So we kind of feed off of each other depending on, where the athlete is. Are they still practicing? Great. Then the AT can really supervise and see what they look like, how they feel, what are they saying to the AT out at practice. And that kind of helps us better understand, are they really ready? Are they, trying to push a little bit too aggressively? So it's very nuanced, trying to get an idea of where exactly this athlete is at. But having the luxury of all these team members makes it a lot easier for us. It's a lot less guessing, and we have a much better idea because we're able to communicate a lot.
And to give a bigger, better picture of what it actually looks like, we're going to go through two, potentially three separate cases today. Joey thought of the idea of discussing one kind of post-operative scenario and specific case, and then one semi-participating in sport. We'll start with post-op. an athlete has gotten injured and they're going to, or they have gotten surgery, question one, where do these athletes actually go for their surgery?
Yeah, so these athletes are really free to go wherever they see fit for their surgeries. Like I said, we do have sports physicians on site. We do have an orthopedic surgeon, pediatric orthopedic surgeon under the Johns Hopkins All Children's Hospital system as well. So typically, what will happen if we do, or if the physician do think that a surgical consult is warranted, they will very likely reach out to the surgeon that is a Johns Hopkins surgeon, and then the patients may or may not consult with him depending on where they live, what their connections are, what their networks are. So sometimes they do consult with him and then either get a second opinion elsewhere, or they consult with him and then get the surgery there. So it really depends on kind of the situation. We do have patients that do fly to certain geographic regions for specific surgeries from specific surgeons. So it's really going to depend on the family, kind of what they decide on is the best for them. We never say go with this surgeon or you have to go here. It's always going to be a discussion that we have with them, or whatever they decide to choose is ultimately what they're going to wind up doing. So they have the luxury of going wherever they please.
Now let's go into one specific case and how that looks immediately post-op. I know you have one in mind, so would you mind just giving a background on this particular athlete and the case and what surgery they got, and then we can go from there?
Yeah. Right before I get into the case, I do want to discuss pre-op visits. So, depending on the scenario, the acuity of the injury, insurance visit limitations, kind of all of those factors, we will try to see the athlete's pre-op if those constraints allow us to. If we do see them pre-op, some of it will be based on those insurance visit limitations. So, if it's something that we feel like can be, performed either on their own or with supervision from the athletic trainer, we will try to do that. So there have been times where I've done an evaluation. We actually just had it with a PCL pre-op where I did the evaluation, kind of took all the baseline measurements of the contralateral limb, took all the, girth measurements, swelling, range of motion measurements of the involved limb, kind of got an idea of where they were at. And then right after, I relayed to the athletic trainer, hey, I don't think this would be something that I have to see this kid 2 to 3 times a week before surgery, because then we're just going to crank through his insurance visits. You know, I'm right across the hall, so I have the luxury of talking with the athletic trainer and the student all the time. So whatever questions the student has for me, like my door's always open, they can come to me. So it's kind of helpful because yes, he's not technically coming to me for PT for his pre-op visits, but I'm still there to answer whatever like he needs and can still game plan with the AT. So I guess you can call it like quote unquote informal PT, but they're still getting, really good quality care leading up to their surgery. And then diving right into this particular case, this student athlete was a football player, post-op ACL reconstruction with medial meniscus repair and loose body removal. He's currently 8 weeks out. And then where do you kind of want to go from here, Chris?
Yeah, what does anything change with the structure of if they're a morning or an afternoon athlete? Does anything change in their day to day now as an athlete at IMG that's post operative? They're not participating in sport. What does it immediately look like for them? And then you saw them, I'm assuming, the first few days or week post operatively. Generally, for this specific athlete, how did things look and go?
Yeah, so obviously school is going to be the most important. We never want to pull them out of school. We will pull them out just for evaluations if there's a scheduling constraint, but we will not allow them to just skip class to come to PT. Obviously, we know school is going to be the priority for them. That's what they're here for. Even though they say they're here for XYZ sport, school is the priority. We got to get them to the next level and they have to have good grades. So that's going to be our priority. And then obviously as a surgical patient, we're not participating in, team lift yet. We're not participating in any practice game scrimmage scenarios yet. So obviously their sport component of the day is going to be drastically altered. So that's when we can really, schedule them out during this time slot that they're going to come in either 2 to 3 times a week with us, depending on the surgery. This student happens to be with me 3 times a week. And then if they're not with us, we can collaborate with the ATs on if they're going to do additional care with them, because to kind of backtrack on kind of how IMG works, the AT portion of rehab care, etc., that's all kind of included in their tuition. Whereas we're insurance based, so they have to obviously go through their insurance. So we try to obviously strategically implement a plan to where we're not burning through too many visits, and then we can collaborate with AT on getting a solid game plan, whether it's 4 days a week, 2 us, 2 them, or 3 me, 2 them. And that's what we're happening to do with this particular patient. He sees me 3 days a week, and he sees the AT 2 days a week. And it'll be like that probably up until the 12-week mark, where we can start doing a little bit more team-based work. And then obviously now that he's able to do a little bit more, we don't want him to overdo it from a volume standpoint. So one of us will back off, whether it's me decreasing a day of frequency or AT decreasing frequency. We'll kind of game plan that once we hit that kind of timeline. And then usually around the 2-week mark, myself, the AT, and the strength coach will all have a sit down, quick 10, 15-minute chat. Here's the patient, he's at the time, 1 week out, ACL reconstruction, medial meniscus repair, loose body removal. Here are the surgical precautions outlined by the surgeon. Here's what we're currently doing in PT. Here's his current plan. Here's what I'm okay with him doing in the weight room based on what I've found. So for example, right lower extremity is going to be totally off limits in the weight room. PT will take right side, AT will take right side, strength will take contralateral limb, core, and upper extremity. And kind of as the plan continues to progress and he gets obviously more healing, range of motion's better, he's able to weight bear better, that exercise menu will kind of open up. So next time I see the strength coach, hey, we just started, partial wall sits. We just started, low box step ups. We just started, open chain, high volume, low intensity, knee extensions, kind of laying out what we've started to integrate. Here are now the next layer of exercises I'm comfortable with adding into his injured athlete program. So he's still not full participation with lift. He is getting, with team lift, he's getting more supervised care with one of the strength coaches that runs the injured athlete program, which is typically like 3 to 5 post-op patients compared to, a lift of 50 kids with 3 to 4 strength coaches. So it's much more supervised, which obviously makes us feel a little bit better because we know they're in good hands getting, supervised, basically kind of that semi-private strength and conditioning. So kind of that's how the first 2 weeks typically look with this patient. We see them, we determine how much they're going to be with us, how much they're going to be with AT. We sit down with strength and kind of come up with a game plan on how we can get them back into the weight room, because obviously we want them to try to be around their teammates as much as possible, especially given the mental and physical hurdles of the surgery. So that's something we try to do within the first 2 weeks of surgery, is have that meeting so we can integrate them back as much as we can.
How much change is there? You said that if it's this early on, you're just utilizing your time spent with that athlete on that surgical limb. So is the athletic trainer. Are you defining what the athletic trainer is doing, or giving those parameters, or do they ultimately have full autonomy to do whatever they'd like? How different are those rehab sessions?
Yeah, so we'll chat a little bit in the early stages. Usually I will take the bulk of the main strengthening. So obviously a lot of it's going to be quad, hamstring. If there's hamstring restrictions, we're going to obviously lay off of that. But I'll take the bulk of, decreasing AMI, decreasing swelling, improving, quad activation, things like that in the very early stages. And then, for example, say the AT will take, accessory ankle, hip, strength, dual tasking work, balance work if weight bearing allows, core accessory work. So we're kind of making sure we're bouncing off of each other and not being redundant. So we will kind of outline what we've done for that particular day or what we're planning to do this particular week. And then we try to space it out so that way he's not doing the same thing every day. So I can also use an example for my current PCL post-op that I have. So pretty much every day after I see him, I will go right to one of the football athletic trainers and say, here's what we did. I'm totally cool with you supplementing, XYZ in conjunction with what we did today. So we're always kind of bouncing back and forth to make sure that the athlete kind of gets everything that he needs throughout the week and it's not redundant for him.
What does their plan look like compared to the first week or two of the structure of their week? AT, PT, strength and conditioning, and then when do you on the PT side start to test this population for ACL?
Yep. So he's still with me currently 3 times a week. He's with AT twice a week, but definitely have dialed back the amount we've been doing as a whole and as like a 2-man team, because now he's doing a little bit more weight room based things. So obviously we want to make sure we're not crushing him with volume, because he's in a point now where we can really start loading him up. So we do want to account for that and make sure he's not doing too much overall. So I've decreased my overall intensities to like two higher days and then one lower day in the middle of the week. So our Monday, Friday will be our higher days, and the Thursday will be the lower day, to make sure that he has relative recovery between the week. And then since AT is mainly doing, accessory based work, balance, dual task type work, it's not really eating too much into his overall workload, just from like a global standpoint. So we're at least able to, kind of push the needle forward a little bit more in those qualities while not kind of, tapping too much into his overall weekly workload as he's beginning to do more. So as far as the testing, I'll typically test him fully about the 10 to 12 week mark, depending on kind of how things are going, because we did have to lay off isolated hamstring work for about 6 weeks. So I might push that a little bit more to the 11, 12 week mark to give us a better foundation for that hamstring strength to start to develop. So I'll test him seated knee extension at 90, seated hamstring at 90, hip abduction and supine, max single leg heel raise, to kind of get an idea of where he's at. Typically, probably at this 10, 11 week, 12 week mark, I'm expecting anywhere from, a 50 to a 70-ish quad index. He's done okay with his anterior knee pain so far. So hopefully he's up to that, closer to that 70% mark. And then that'll help kind of guide our pre-plyo phases. When are we starting our, quicker eccentric based work, our pogo progressions, maybe some snap down progression or med ball chop progressions, which would kind of layer into our return to run process, most likely at the 14, 16 week mark, where we'll test again. So if we test at week 10, we'll probably test again at week 14, to kind of get an idea. But what I've been doing lately with a lot of my ACLs that I've found just super helpful to kind of get an idea of where they're going to be at when I do formally test, is I'll set them up with a tin deck right after they do their NMES. I've been doing NMES with straight leg, and then taking NMES off, going right into seated tin deck isometrics at 60 degrees or so, and then having them warm up, X number of sets as much as they need till they feel like they're in a good spot. Then I'll have them kick as hard as they feel comfortable without it going above a 2 or a 3. And boom, I'm going to kind of mark or put a mental note in my head. Okay, they were at like 60 pounds today. Then we're going to kick at 70% of that 5 times, 15 to 45 seconds, depending on how far along they are, how much discomfort they have. And then once I do that multiple times, I slowly start to see their peak creep up and up and up and up. So if they're at the 10-week mark and they've been kicking like 50 pounds each time, or they're going from 50 to 55, when I test them next week formally, I'm probably not expecting them to be, at 80. So I have a general idea of where they're going to be when we do test. So I've just found that to be kind of kill 2 birds with 1 stone. Let's maybe 3. Increase their motor unit activation, hopefully help realign some of the collagen in the patellar tendon, and then get an idea of kind of where they're going to fall when we test them. So I found that to be very helpful, and it's been pretty close to what I've expected when I do test them. And it's also helped a ton in reducing the risk or the recurrence of any anterior knee pain that they've had. Not to say that I don't get it, but I've noticed since I've started kind of using this retest that it's gone down a lot in terms of frequency.
Yeah, just a kind of similar experience in our clinic. the way that we'll structure it a lot will be as soon as possible, we'll get them edge of table and we'll just at 90 to 60-ish degrees have a stability ball on their anterior shin, and they're doing submax isometrics at that to see how the entire knee extensor mechanism feels over a few weeks. And then around the 6 to 8-ish week point, if they can get there, we'll set up on a 10 deck and start doing 30 to 45 second ISOs like you're doing, see where they're averaging, and they're getting used to that position and just feeling confident putting out force. So around the 12-week mark, when we actually get a true peak force measurement, it's not a completely new experience. The series of tissues is used to this, and we ourselves as the clinician have a better perspective of where they're probably going to sit. So I like that y'all do that. You going back, you had mentioned currently he's kind of at 2 high days with you and 1 low day. What does that actually look like and mean for you?
Higher days meaning a little bit more intensity. So we'll do, typically I like to start them out, especially if they're within like 5 months out post-op, is with a pretty heavy loaded single leg exercise. So whether it's, a higher box step down with his back against the wall to really limit any sort of trunk compensations, whether it's a rear foot elevated split squat with a foam roller as an external cue, whether it's, a single leg squat with a foam roller on their back where they can't tip it over. Typically like one of those 3 exercises I'll kind of roll with first. Starting with tempo based, probably from week 4, if it's a tolerable movement for their knee, up until like week 8, like 3 up, 3 down, 1 up, or 3 down, 3 up, to really just start rebuilding that foundation from a control standpoint, motor learning, hypertrophy, overall strength. And then I'll kind of start to decrease those tempos and increase the external load a little bit more, especially once joint effusion goes down, once they're feeling more comfortable, and just once the overall movement quality looks a lot better. So those will kind of go from, your 303 tempo loaded fairly light to like an RPE of 7 to 8, to now we're backing down to like, 1 to 2 seconds down, 1 second up. And now we're really going to bump up the external load a little bit more, still sticking at a relatively high RPE, but now our goal is less on, tempo and control. Now let's really start to move some weight. So that's kind of how, block A will look. And then either a unilateral staggered stance or bilateral, posterior chain exercise, whether it's, trap bar deads, barbell hip thrust, single leg hip thrust, kickstand deadlift, something like that, where we can, load the backside a little bit heavier. And then I'm going to go with, quote unquote C part of the session, where it's a little bit more accessory based, whether we want to hit a little bit more, isometric quad. I like to hit at least, 2 different contraction types throughout the session, whether it's eccentric, our A, and isometric as our C. And then maybe potentially pair that up with either adductor, abductor, calf. And then if time allows, or if they're still feeling good, BFR, 1 to 2 exercises tops, and then done. And then typically that'll be whatever I did on Monday. I'll kind of flip flop the exercises on the Friday where it's still a high day. So we're not going to do, your single leg squat with your back against the wall twice. We're still going to do, a knee dominant unilateral based or asymmetrical stance based first, to make sure we're maximizing that quad hypertrophy and fatigue. And then going into some sort of derivative of a posterior chain movement. Your C is going to be more quad based, pair it with an accessory, and then BFR if time allows. And then typically the middle of the week, it's going to really depend on kind of how they feel. A lot of what I've learned so far is that it's very hard to control high schoolers when they're in a setting like this, because it's totally different for them. They're away from home. They can really only stay on campus. There's other kids that are around them all the time. So they want to hang out. They want to, do the next cool thing. They want to stay up till 4 a.m. So a lot of my plan does have to be fairly auto-regulated to account for that. So your plan A is likely not going to be the plan that you roll with for that particular day. So I've learned to be prepared to have a plan B or a plan C, depending on kind of how they present. So if, they come in fried and we had a higher day planned, I'm probably going to shift that day to the low day and then kind of modify the rest of the week. I wish I did have the luxury of being able to write out all these programs for everybody, but just with the sheer amount of athletes, I would run myself into the ground. It would be nearly impossible to do. But I've kind of found that this layout that I currently have has been working for me from like a mental modeling standpoint. So I've been able to kind of just plug it in my head where it fits and then just swap whatever I need to swap depending on how they feel for that day, or kind of alter whatever the objective is for that day and switch it to something else because, they did too much in the weight room, or they were out too late in their friend's room playing video games, whatever it is. So I've learned to have to auto regulate a lot, with this population. But going back to like the lower intensity day, that'll obviously be dialed back in terms of the amount of intensity. It could be a little bit more higher volume based, but more like work capacity. So pairing like 2 exercises together to start and then like a 3 exercise circuit to finish or something like that, where they're not, we're not crushing them, but they're at least able to get their heart rate up, their work capacity is going up, their endurance is going up, and they're still getting some sort of, strength hypertrophy piece without, running themselves into the ground. So that's kind of what my weekly structure has been with this athlete. And I will say it's worked well up until he's felt the need to go lift outside of IMG, which has also been an issue with some of our other athletes. They're at such a great academy with all these resources, all these great strength coaches, everything that I wish I had as a high schooler. And then they feel the need to go to Crunch Fitness after school. So like we have to have these educational talks with them, like more is not better. Do what you're doing right now better than you've been doing it. So kind of just getting them to understand that, because they just think that more is going to make them better, when realistically, if you come in and you can't walk because you did, 5 sets of 15 leg press, pretty heavy, yeah, like we're gonna have to rethink what we're doing for PT today. So that's kind of what I've been running into a little bit more frequently. So there's been a lot more kind of sit down talks with me and the AT, just kind of making sure that we're all on the same page, that we're looking out for them. We're not saying don't work out. We're just saying, hey, just take it easy here, So that's kind of what we've run into in multiple scenarios.
Well, earlier on in this call, I was going to say these kids sound dialed. It's like a military academy, but then you just touched on kids are kids and humans are humans, and there's just going to be things that you can't control, and that auto-regulatory piece that you utilize, and having that as a framework for determining what they can tolerate and not just enforcing this is the plan, we're going to have to do it because this is all I have. That makes sense, especially for high schoolers, even if they're at an elite academy.
And you brought up a point that I want to hit on here. Given that it's a boarding school and it's full of kids that are, many of whom are away from home and are away from home for the first time ever in their lives, we do run into those kind of psychosocial pieces where, a kid's homesick, or they're not fitting in well, or they really don't like their sport as much as they think that they did. And now they're forced to basically be treated as a collegiate athlete. Like, here's when you go to school, here's when you lift, here's when your nutrition is, here's when your leadership is. Sometimes it's just like a complete shock to their system. And then they develop, their chronic pain, things that are hurting, and they feel good, then they hurt again, they feel good, they hurt again. It's just like an endless cycle with some of these kids. And once you kind of give them some sort of reassurance, or like try to help them out in any way that you can, typically you'll see them feel a lot better. Like I've had a lot of spontaneous recoveries where, I was telling the ATs, I think, this could be like 2+ month thing based on what I'm seeing. They come in on Monday, oh, like I'm feeling fine. And I'm like, okay, maybe they just needed some sort of reassurance or someone to tell them like, hey, everything's fine. There's nothing to be concerned about. We can still train, we can still participate. We just have to modify what we're doing a little bit. And sometimes that's all they need to hear for them to feel a little bit better. So that's something that I've had to learn, is to take that into account. Like, you're not just being dropped off at PT by mom and dad, I'll see you in an hour and pick you back up. Like, no, these kids are alone for the most part and really only communicate with their parents by phone calls or FaceTime. So it does create an added layer of complexity, especially when something isn't going too well for them. whether it's, school, personal life, sport, you name it, it does create a challenge sometimes, just given the nature of how the academy runs.
Before we move on to the second case and the semi-participating in sport phase, or that type of portion of rehab, these longer term recovery and injuries like an ACL reconstruction, you're in a setting where there's a very high expectation that these athletes are going to play collegiately and probably at the highest level. They're surrounded by freak athletes and extremely high achieving young kids. How does that go from setting expectations early on, whether it's preoperatively and maybe the parents have flown in and you're discussing with the entire family or just the kid, or what is that? I'm sure it's very dependent on the athlete and the situation, but maybe you can stick with this specific kid, or more generally these ACL longer term recoveries. How does that go in an academy like IMG where they're going there to play college? I'm sure that's a really hard discussion to have, where this may, what is this change for them?
Right. And going into these evals, especially if it's a high profile athlete, like I have to kind of understand what their situation, what their future situation is. And I don't want to be the one who, you know, interferes with that process. Obviously, my goal is to return them as safely and as quickly as possible. But again, I understand that there are certain times where timelines are very important, and needing to be ready by, a showcase or like a team workout or, a field based workout is super important, because it can allow them extra film. It can allow them extra, discussions with coaches or extra exposure. Like I have to understand that and know that their end goal is to get to that next level. So I'm kind of thinking of that already in the back of my head. So when athletes come in, I can even use this athlete as an example. The parent, straight up said like he needs to be ready in 7 months, and already I'm thinking to myself, we were going to lay out expectations anyway, but I'm just thinking like, okay, this could be one of those more difficult conversations with the parent and with the kid, to ensure that, like I said, we're returning him as safely and as quickly as possible without being stupid. Right. So I have to make sure that I lay that out. And I'll usually say right on the eval, obviously you got XYZ procedure. What is your understanding of the procedure that was performed? And like, what are your expectations, or what are your understanding? What is your understanding of the expectations? And I have them like flat out say it to me, just to get an idea of either where their head is at or where the family's head is at. And that'll kind of dictate the education that I'll have to provide them. Like this is very likely going to be a 9 to 12 month return to sport. And given that he got surgery about 2 months ago, I relayed to them that we are in a probably the best time of year for you to have gotten this surgery, because we have from what was it, the early November all the way till September when the first game is. So that allows us at least 11 months, 10, 11 months, right? So already we're in a good time window that we want to be in. So kind of laying that out to them, that it doesn't seem like we're going to be in a time crunch for the start of the season. However, they expressed that they need to be ready by a certain collegiate workout, which may ride on a potential scholarship offer. So that's another, layer of complexity that I have to, account for. And I didn't say any, yes, you will be ready, or no, you will not be ready. I always tell them it's going to be a little bit gray. Obviously, it's going to depend on number one, time, and two, are you achieving or close to achieving the objective criteria that we want you to hit? And I'll kind of lay out to them once what that criteria is and what it means when I do the actual test. I won't really go into the specifics on, day one, just because it's so much information. But just getting them to kind of understand that this is going to be a long process, and it's not just going to be based on time, and we're not just going to return you at 7 months because you want to. It's going to really be, a team effort. All of us are going to give our inputs, whether it's me, your surgeon, your parents, the AT, like we're all going to talk it out and make sure that we come up with the decision that's the best for you to succeed, not only for this upcoming season, but for the next level, because we don't want to put that in danger either. So it does become a little bit difficult in these situations, especially when we're dealing with, strict timelines or people who have a lot of offers and they need to make a decision. So again, something that we really have to keep in the back of our head when we're dealing with these athletes.
Has there been periods where you've had to clear them early, or at least describe, my clinical or professional recommendation is that we wait until XYZ occurs? Either it's this timeline or these objective criteria need to be met. As long as you're comfortable with understanding the potential elevated risk, we don't know exactly what that number is, but as long as you're comfortable with that, I'm okay with this occurring. Like, how does that go? Is there just, there has to be more give and take in this particular setting?
Yeah, this happened actually probably a month ago. Post-op radial shaft ORIF football player, post-grad. So obviously, again, bit of a time crunch. There was only one game left in the season, and he had no film because he was injured last year with another fracture. So I kind of already knew that we're probably going to have to be a lot more aggressive with, one, what we're doing in the clinic, and two, maybe a little bit more lenient with the criteria that we want him to hit prior to playing. So leading up to his final visit with his surgeon, I kind of explained to him, there's kind of two different clearances we look at. Number one is going to be your orthopedic clearance, right? You go to your surgeon. He says, your range of motion is fine. Your strength with manual resistance is fine. You have no pain with daily activity. Everything looks good from a surgical standpoint. We re-imaged you, it's fine. You're cleared to go, right? So that's one piece of the puzzle. And then we have two, your sport clearance. So you could be cleared from an orthopedic standpoint, but you also have to understand that you might not necessarily be cleared from our performance standpoint because there are criteria that we want you to achieve. So we kind of already had that discussion going into his last visit with the surgeon. And then he comes back to me. Surgeon cleared me. He cleared me to go full contact. I'm ready to go for the game. I said, let's backtrack a little bit. I'm not saying that you're not going to be cleared, but we have to do some sort of assessment battery to make sure that you are ready. So it was a little bit of a time crunch for me because the game was only in a few days. So I kind of ran him through my own, quick semi battery. I would have loved to be able to do a little bit more. But we basically did handheld dynamometry, ER, IR, scaption, flexion extension, grip strength. Those all looked solid, but not where I would like them to be for full clearance. They were about like mid 80s. But again, understanding, what the timeline is, that was something I was okay with him being at, from like a risk perspective. Quick closed kinetic chain upper extremity test. He breezed through that. All right, we got to do something a little bit more intense, a little bit more closed chain dominant. Ballistic plyo push-ups. You're going to start in a bottom of a push-up. You're going to throw yourself up, land on plates. Okay, great. That feels fine. Now you're going to be on the plates, drop down, stick the landing at the bottom. We're going to slowly increase height. How do we feel? We're good. Fine. All right, let's move on. We're going to do, max single arm bench. What's your LSI at, 50% body weight? Just to get a quick idea. Okay, I know wouldn't be my typical testing procedure, but, we got to kind of move here. So getting an idea there. Then we're going to head over to the Kaiser. We're going to go max peak power, single arm punch. Are you within, I'm okay with 85%. What's your peak power on the screen? Right arm, left arm. Are we there? Boom. Okay, let's move on. So we've got isolated strength. We've got closed chain control, closed chain strength, open chain, like pseudo upper body / trunk power. Hits all those. Okay, you've given me enough of a sample size for me to be okay with, you can go back. I understand that you're probably going to be at a little bit of an increased risk just because, one, we're not quite there from a strength standpoint, and two, from like a chronic workload standpoint, you haven't had, as much as we would like. But given the scenario, given you have no film, let's do this. This is your last shot. We have to allow you to do that. If it was totally inappropriate, obviously I would convey that. But we were kind of teetering on the edge of it being appropriate versus potentially waiting a little longer. So that was a scenario where, me and the athletic trainer said, hey, like, we have to let him go. So he went and he wound up getting through the game.
Wild. Thanks for adding that specific case. Let's go into semi-participating in sport. What particular athlete do you want to discuss with this timeline?
Yeah, so this will be a UCL sprain athlete, a baseball player, outfielder. So I just recently saw him about 2 weeks ago for his initial eval. Had some on and off elbow pain like late summer, ripping some balls from the outfield to either home or some cutoff men. I started to have that medial elbow pain, shut down for about 2 weeks. Did about a week long ramp up, went back again, still uncomfortable. Saw the AT suspected, UCL sprain. He wound up contacting a couple different doctors in the area. I think he contacted one doctor locally and then two, I believe, from back home that he saw. So he had a couple different opinions on this case. It wound up being a UCL sprain. The opinion that he went with was the conservative management route. So PT indicated here. So he was sent to us. So kind of backtracking a little bit, typically with these cases where someone's semi-participating, what will usually happen is the athlete will first see the athletic trainer. The athletic trainer, if they think it's appropriate to be seen by the sports med, will refer to sports med. If sports med thinks that it'll be relatively short term, he probably won't prescribe PT and something they continue rehabbing with AT. If it's a little bit more long term or a little bit more nuanced, then they'll come to us. So that's kind of usually like the chain of command with cases like this. But this athlete happened to not see our sports med. Like I said, he went locally here in Florida and then back home. So ultimately, he wound up with us anyway, and then was diagnosed with that UCL sprain, like I mentioned. So that's kind of that continuum or chain of command when it comes to this particular case and most cases where someone is semi-participating.
Now that they're with you, they've gone through that chain of command. What does it look like for this particular athlete from what you're currently doing with them, ATCs, strength coaches, and what are they doing actually in practice?
Yeah. So obviously they'll go through their initial evaluation day one. So day one, I'm looking at just global range of motion, neck, spine, hips, knees, shoulder. What's their total arc of motion? Handheld dynamometry, ER, IR, scaption, abduction, grip strength, UCL special test cluster, getting them on the table. What's their dynamic valgus test in supine? What's their milking sign? What's their prone valgus test? What's their palpation, irritability? And then kind of given that, I'll have a better idea on what their potential return to, whether it's hitting, throwing, grip-based weight room things are going to be. So he was still very tender at the UCL. One of the three tests was still positive, so that tells me still we're dealing with a moderate amount of irritability here. So kind of what I lay out to the athlete in terms of getting back to at least baseball-related activity, and I kind of explain it exactly like this. I'll do the dynamic valgus test in supine, and I'll ask them, is this still pretty painful? If they say yes, then I typically say, we're going to hold off on, any sort of throwing until this is pain-free, because odds are if this is painful on the table, what is it going to be once you start throwing? And usually they can answer that question right away. It's going to be painful. So I'll kind of relay that with them that I want to see everything on the table be fully pain-free, all special tests for the UCL be negative before we initiate any sort of upper body plyos or interval throwing program. And if we are kind of at that interval throwing program, time period, I do want them to get at least 1 to 2 weeks of upper extremity plyometric progression to at least build that foundation before we start throwing. So that's what I'm looking for from like a strength standpoint and special test standpoint. Regarding the strength, the numbers that I'm looking for him to at least initiate throwing is going to be around that 85%. So he was actually there. So he had the grip strength, he had the ER/IR strength. ER/IR ratio was very good, but special tests were positive for UCL. Total arc was good, but shoulder flexion, horizontal abduction we had a lot of work to do. So I kind of told him that you are in a very good spot in terms of your strength. I'm not concerned about that at all, but we are severely lacking in terms of the motion that you need for your arm, right? If you're an outfielder and you can't get on top of the ball to throw to your cutoff or, shoot one home, you're going to be compensating elsewhere and likely putting increased stress on your elbow. So we really need to clear up these range of motion deficits first before we can progress to anything else. And I don't know what his prior range of motion was, but I'm assuming that it was limited because now this is the second time in 2 years that we're dealing with a scenario like this. So maybe those residual deficits are kind of the reason we are where we are now. I don't know for sure, but I told him that's kind of what what I was thinking in terms of why this is something that might keep coming back.
Now you've established regaining that range as a priority. What are you currently doing with him?
So currently right now, we are starting out with some soft tissue work, decreasing some tone in the back of the shoulder, working on some active loaded mobility. So for example, we're doing a lot of lat type stretching, like positional breathing type work where he's grabbing onto TRX strap, leaning over to the side, big breath in, inhale, big breath out, sinking to the stretch a little bit more. Loaded kettlebell pullovers, downward dog progressions, crawl variations, and then following that up with heavy eccentric lat pull down work, heavy eccentric row work to try to elongate the tissue as best as we can. Which has resulted in some short-term changes of range of motion, slowly improving. He'll come back in with some occasional stiffness, but overall we're trending in the right direction there. So my priority is not to get him stronger overall as an athlete. Like that is the strength coach's job in this scenario. So I kind of have to understand in these semi-participation patients, like what my role is. So more so I'm taking the lead on the strength with our acute post-op like we talked about. Now I'm more so taking the initiative on what is their impairment? How can I best resolve that impairment? Because they're already out lifting, doing most of the things in the weight room already. He has had no pain with any grip work at all. So I've given the green light on basically everything in the weight room. Now my role is to focus on what his impairments are and try to help resolve those deficits. So kind of my role changes a little bit depending on if this person is participating to some extent or a little bit further along versus are they a post-op patient like 1 to 5 6 months out. So my role changes based on the case.
If he, let's say he tests negative on that UCL cluster tests and he still doesn't have that range that you were hoping for, would you still begin the interval throwing program or throwing in general?
That's where it becomes a little bit difficult, and I feel like it's a nuanced situation where you have to kind of just go with clinical reasoning. I'd like to get him within 5 degrees of the contralateral extremity. If he's within like 7, I'm not going to make a huge deal out of it, but I'm expressing that this is something that I still want to make sure that we're staying on top of, because especially now that we're potentially going to be initiating a throwing program, the backside of your shoulder is going to get tight and it's going to probably feel a little bit sore and tired. So we might see those range of motion changes in a negative way once you start throwing. So we really need to make sure that we're staying on top of this. So that's kind of what I'm conveying to the athlete. And it is difficult. Like if we're just trying to get as much range of motion back and it's just taken a really, really long time, like I understand that I can't shut this athlete down for 3 months to gain 6 to 8 degrees of range of motion back. Like to me that doesn't make sense to the athlete. He's having no pain with any weight room stuff. Hitting's fine, base running's fine, shagging balls in the outfield's fine. Really the last hump we have to get over is can he throw. So a difficult answer. I wish I had like a better answer, but it always is going to depend on kind of the scenario at hand, which will kind of guide what we do next.
Do you want to compare this semi-participating sport, this baseball UCL's example, to a lower extremity athlete or injury or
Yeah.
separate sport?
Yep. So let's finish with the baseball first in terms of like green light versus red light. So like obviously throwing is going to be a red light. So I'll convey to this athlete, base running, we're good. Fly balls, we're good. Tee work, we're good. Front toss, we're good. Basically anything where you're not throwing, I'm okay with you doing. Because obviously baseball is going to be a little bit different than your field sport athletes where there's a lot of, lower extremity change direction and other components involved there. So from the throwing standpoint, that's going to be the only thing that's going to be off limits for now. Versus, say, a field sport athlete. I had a grade 2 ATFL ankle sprain a couple months ago, and kind of layering him back into sport. I've learned to be very specific with what I say to the athletes in terms of what they can versus cannot do, because they can kind of take that 1,000 different directions. I remember in one of my residency mentoring sessions, I was being mentored during a session down here actually. And, the patient asked like, what can I start doing? And I told them, you can start doing like light passing stuff in place. And then after the session we debrief, my mentor's like, what the hell is light passing stuff? What does that even mean? And that kind of like a light bulb moment for me. Like these kids can kind of take that and run with it in 1,000 different directions. So with this particular athlete, I'm literally saying our first step back, you are only allowed to do linear movements only. So anything forward, anything backward, no defender, no contact. And I say it specifically that way so there is nothing that could be confused, right? Even though I'm telling this to the athletic trainer too, like what they've been cleared to do, the kid also needs to know exactly like what our parameters are. And then once that progresses a little more, now we are strictly linear, we are strictly lateral, no contact, no defender. Now that's going to change to linear, lateral, multi-directional, no contact, no defender. And we're kind of layering that in. Now we can add a defender with all these three components. Now we can have, our 2-on-2 drills. Now we can have our 3v3, our 5v5, our scrimmage play, and then our return to sport. So I've been much more considerate with how I word it to the patients because, again, like we talked about, they're kids and they can take that 1,000 different ways. So being very particular with how I word what they're going to be doing, especially when it's the field sport athletes, when it's a little bit more chaotic on the field with kind of what we know can happen on the field. It's very chaotic. So being much more descriptive really gets them to buy in. And I even use like the teach back method. All right, what did we say? What did we discuss? It's what? And they repeat it back to me to make sure that we're both on the same page.
Yeah, that's a great point. I was thinking of a specific athlete that I've discussed certain things with, and I was probably way too vague. I think I said like at not 100% intensity, something like that. And that is, yeah, just being extremely specific with your, what you will and will not allow and what that looks like for them and making sure that they actually can say that back to you. I didn't ask you this question in our outline, but because you have essentially, well, 100% all day, every day, just these 7th to 12th or, an extra year, you athletes within this age range, that's all you see. What is your, over the past year or two that you've been there, general reflections and recommendations for physical therapists or providers working with athletes, youth athletes that maybe they're not in your setting where they see that's all they see, but they're in a typical like outpatient orthopedic or sports setting, it's a variety of ranges with just the sheer exposure. Is there any big kind of takeaways that you have for other rehab providers that will work with these athletes of these ages just because you see them literally all day, every day?
Yeah, I actually forgot to mention a big piece in the beginning that we do sometimes see outside patients. So IMG is also a destination for, collegiate and professional athletes to either, come train, rehab if they're injured, go through like combine prep or, private workout, things like that. So there are times where we do get some professional or collegiate athletes in. So that obviously changes our dynamic a little bit. especially when we do get the pro guys in. It does add a little bit of a layer of complexity because one time I was having to deal with the actual organization, the player, and the player's agent, kind of filling them in on, how things are going, expectations, prognosis, things like that, which was totally new to me. I didn't even know that would be a scenario I'd be involved in. Even once he came in, like that didn't even cross my mind. So that was a little bit of a, wake up call to me, like that these scenarios are possible. So kind of just understanding that there are other parties involved when you are dealing with that type of population as well, the professional setting. But kind of going back to the youth, I think the biggest thing is kind of what we talked about, that these are just kids, right? They're obviously committed to their sport and they want to get to the next level, but any kid in general is going to act like a kid in most scenarios. Like they're going to want to play with their friends. They're going to want to stay up late. They're going to want to scroll TikTok. They're going to get distracted. They're going to have days where they're anxious. They're going to have days where they feel good. They're going to have days where, they feel like crap. So just kind of understanding that most things you have planned with this population are not going to go as planned. So always having, an exercise regression in your back pocket or a lateralization in your back pocket or a complete session switch in your back pocket. Like, okay, we had, jogging and, linear acceleration or whatever plan for that day. Well, that's out the window. What am I going to do next? Because a lot of times in residency, we had to write out for our pre-mentoring sessions, like what do we have planned for that particular day? Why do you have that planned? How do you think the session is going to go? And a lot of times I basically in my brain had to rip that piece of paper in half because we couldn't do any of that. So just knowing how to be adaptable and being able to kind of change on the fly is really going to help yourself grow quickly. Once you get into the swing of that, 10, 15, 20, 30, 50 times, then it's going to get a lot easier when you are hit with another case where, everything that you had planned is not going to go to plan just based on how this kid presents. So just kind of knowing how to, auto regulate not only that day, but how it's going to play into the rest of the week, too, I would say is the biggest thing is just understand that there's going to be a lot of external factors at play with this youth athlete population.
Any other final thoughts, recommendations before we call it?
If you don't happen to work in a multidisciplinary setting and you are working with youth athletes, I know there's a lot of time constraints in outpatient clinics, but if you're able to, always try to communicate with some other provider that is involved, whether they're at a high school and the AT is there. Like if you have like 2 to 5 minutes in your day, see if you can just shoot them a quick email, give them kind of like the lowdown on what PT has been looking like. What is rehab been looking like, or what has field work been looking like while they're at their school, just to get an idea and have someone else that you can bounce ideas off of. And who knows, maybe that can turn into, a networking opportunity, or they know someone at a college and, you hit it off with them and they recommend you to that college. So it could always turn into something that you don't know it might turn into. So just take your time, do your due diligence and reach out to, whatever professional is involved in their care also, if you can. And it's not only going to help you, it's going to help the athlete, because obviously it doesn't matter who returns them to sport. Like we're working as a team. I don't care if the AT did more. I don't care if strength did more. Like I really don't care. I just want them back in their sport. It doesn't matter who did it. We're going to be working together anyway. So that's really the goal, is working as a team to get them back. So reach out to other providers when you can.
All right. Great recommendations. We'll call it there. Thank you again so much, Joey.
Thanks for having me, Chris.